Spoken with true confidence. I love it. Okay, it's a unilaterally extended sacrum. So what do you think we're going to do? Yep. Are we going to internally rotate? We're going to nutate it, absolutely. Now we're going to get localized through abduction, but do you think we're going to externally rotate or internally rotate the leg? We're going to externally rotate it. Why? We're going to open up the SI joint from the anterior aspect. And what I've been meaning by that is that by externally rotating the limb, we're doing that at the SI joint. We're spreading it open. By internally rotating, we're doing this. We're gapping in the back. So by internally rotating the leg, we're gapping the back. By externally rotating the leg, we're gapping the front. Okay? That's what we're doing.
What's the secret? Don't you need to externally rotate it like a little more in order to get that open?
That's why I said that you're going to continue to palpate at the sacral base until you feel it. That's mine.
Oh, you're giving away coffee.
I haven't even drank it from this morning. I don't even know if I should, actually. I meant to drink it earlier, but it didn't happen. All right. So if you follow along on 359, it's pretty straightforward. Exactly what we were just talking about. Abducting about 15 degrees, okay? And then externally rotating the hip to help anteriorly gap the SI joint. Okay? That's important. Now the only difference here, the other big difference here is the other technique we were facing the head of the patient. Now we're going to have to face the foot of the patient because we're going to be working over the sacral base. Okay? And the other thing too is very much like when we did the sacrum down here. Remember, this sacral base is up, so it's extended. Okay? And it's off its axis, so it's going to seem pretty fishy to think about it like that. So what we need to do is we need to, again, position our hand that we could ulnarly deviate and then drop this down into flexion because it's already stuck posteriorly. Okay. Now there's an added tricky technique that goes with the correction, and it involves providing resistance through the ASIS on the same side. But when we get to that, I'm going to get to that right now. I'll tell you about it. So the left hand of the operator is on the ASIS, providing counterforce against the compression through the right hand. Okay? So we're actually holding one and moving one. That's what we're doing. Okay? And then the patient performs a series of forced exhalation efforts, because with exhalation we're going to introduce the motion we want to do at the sacral base, while the operator maintains a ventral and caudate compressive force over the right sacral base. At the end of each exhalation force, the patient is also instructed to pull the ASIS towards the table as a muscle activating force. And that's going to be repeated 3 to 5 times to help with the muscle energy. Now, my rationale behind it, though Dr. Greenman doesn't really mention it, is that if we're resisting that motion at the ASIS, it's very possible that we're working on the iliacus muscle, right, to help us with the muscle energy technique. But he doesn't mention it. I just was kind of brainstorming that myself. So it won't be asked on the exam. But if you want to write it down and know it, that's fine. Better yet, do a study and prove it, then we can all get published together. So that's fine. Publish or perish, that's what they say. All right, so we're first going to get localized with the exhalation, and then we're going to ask for that pressure of the ASIS downward into the table. And then at the end of that instruction, once they're finished, you're still going to maintain your contact down. You still have to go P to A through the table. It's just that you're on the sacral base at this point. Okay. So who wants to come up next for this one? Marius, come on. So you can lay down on the table. Good. So what I want to do to first get an idea for localization, find the PSIS. There we go. I'm going to drop down into the sacral sulcus. I'm going to abduct the leg about 15 degrees until I feel motion starting to occur at my palpation point. I'm going to externally rotate the leg. Oops, sorry. Didn't mean to mobilize your malleolus then. Until I feel, again, motion occurring at the sacral sulcus. Now the idea here, again, is to gap the front of the SI joint. My contact to help with my shear direction, my shear correction first, is again going to be the same kind of contact. What I want to do is make a contact of the sacral base with my pisiform. Okay? And it's shown slightly different in the book. I'm just giving you this suggestion because it makes it a lot easier. I'm now, my fingers are angling out, lower onto an angle. And now to help correct for the shear, I want to ulnarly deviate. So now my fingers are pointing straight down, running parallel with the spine. So I've now corrected the shear. Okay? And I'm still now maintaining my P to A pressure. Okay? So I'm correcting the shear with my ulnar deviation. I've got now P to A pressure. Next thing I want to do is just contact the ASIS because I'm going to use that later. I'm going to ask him to take a deep breath in. Feel the motion there. Breathe out. Helps me to get localized. Now I'm going to ask him to try to pull his ASIS down into the table. Hold. Feel the motion underneath my pisiform. Relax. And I go further into the P to A. Driving the right sacral base downward into nutation. Because of course, remember, this was a posterior unilateral extension on the right. So it was stuck in counter nutation, and it was in that deviated position of a superior position. So what I need to do with my pisiform is knock it down straight and then put it back into place. Okay. These unilateral extensions you'll probably see more frequent than the unilateral flexions, because more people are subject to fall backwards and slip onto something than they are to be in an extended position and a force come at their low back. So this one you'll see a little bit more.
I can't see, maybe you mentioned probably missed that. I can't see how if you contract the ASIs pushing to the table you contract the iliac disc, how does that going to help the sacral motion?
Honestly, I haven't found a good resource that they utilize in the text. I still always look for things like that from day to day. Right?
I kind of was thinking of that too, but I don't know, maybe this could be wrong, but I was just thinking, because iliac is essentially, from its origin, pulls down the spine into extension, which would nutate the sacrum, theoretically. So I think that could be it.
Yep, that could very well be it. I mean, that's definitely right on target with some good clinical thinking.
Did Frank just have a moment?
Yeah. Very good, Frank. It's making up for being late last week. But like I said, I started off by saying he's making up. Very good. What's gonna? But what I promise that you will feel when you resist that ASIS, you'll feel the movement right away underneath that pisiform contact. So like I said, it's sort of hard to talk about it sometimes. I'd rather that you feel it, and you'll see exactly what I mean. Feel okay? Okay.
So the motion,
ASIS, trying to bring the ASIS down to the table, not necessarily hip flexion. I guess it would be resisted, reverse hip flexion.
Okay. All right. Right. When you first said it, I thought it was like a rotation thing, like just bringing it into the table, like just
Nope.
leaning.
You're just lifting it up, and you're asking to try to push the ASIS back down into your hand towards the table. I'll talk you through it. You'll see what I mean.